Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters on behalf of the Islamic Medical Association. We have our guest in studio tonight is Dr. Ebrahim Hoosen, an orthopaedic surgeon who is a graduate of the University of Witwatersrand. He did his undergraduate there and also completed his postgraduate there. He is currently a consultant at the Charlotte Maxeke Hospital and is also in private practice. But before we proceed with Dr. Ebrahim Hoosen, we will begin with the tarbiyah as is customary. A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. A Handful of Salt by Abu Muhammad Yusuf. As humans, we are prone to stress, although we all wish to be immune from it. While stress may be beneficial at times, however, the excess of it will certainly affect our health and productivity. In controlling stress, our mindset is so important. There was once a very old sheikh who noticed his student very depressed. The wise scholar instructed the unhappy young man to put a handful of salt in a glass of water and then to drink it. "How does it taste?" the sheikh asked. "Awful," reported the student. The sheikh chuckled and then asked the young man to take another handful of salt and put it into the lake. The two walked in silence to the nearby lake, and when the student swirled his handful of salt into the lake, the wise old man said, "Now drink from the lake." As the water dripped down the young man's chin, the sheikh asked, "How does it taste?" "Good," remarked the student. "Do you taste the salt?" asked the sheikh. "No," said the young man. The sheikh sat beside this troubled young man, took his hands and said, "The pain of life is pure salt, no more, no less. The amount of pain in life remains the same, exactly the same, but the amount we taste, the pain, depends on the container we put it into. So when you are in pain, the only thing you can do is to take it out of your cup and place it in Allah's lake." No doubt, what practical measures or action that are needed in the situation must be taken, but we should then leave it to Allah. Allah Ta'ala, who is ultimately in control of everything. Always be positive and forget about the bad things or events of the past and think of good things. Always having hope that it can be better, it will be better. Trying to change the past is foolish and a crazy waste of time, for saying "if only" opens the way to shaitan, said the Prophet of Allah sallallahu alaihi wasallam. The messenger of Allah sallallahu alaihi wasallam said, "Know that victory, achievement comes through patience, and that ease comes through hardship. None can destroy iron but its own rust. Likewise, none can destroy a person but his or her own mindset. Ups and downs in life are very important to keep us going. A straight line, even in an ECG, means we are not alive. The same boiling water that handles or hardens the egg will soften the potato. It all depends upon our reaction to stressful circumstances. Allah the Most Wise says, "And in Allah alone should the believers trust." So the next time you face a problem, don't dissolve it in your own small cup, but cast it into Allah's lake. Sadaqallahul Azim. Welcome to Dr. Ebrahim Hoosen, and the focus of the discussion tonight is on knee pain. Welcome, Dr. Hoosen.
Jazakallah.
Okay, perhaps we can begin with what is knee pain. We know that the knee pain comprises of bony structures, and you can speak more to that around the anatomy of the knee and what is actually knee pain.
Okay, one of the reasons for discussing knee pain today it's been stated that approximately 25% of all adults experience knee pain during their lifetime. And it's been said in the last 20 years the prevalence has markedly increased. And the general orthopedic surgeon, the knee joint is the largest joint and is the most common joint to be complaining of regarding knee pain. To understand why we have knee pain, I think it's beneficial to go into the anatomy regarding the knee joint. The knee joint is a complex joint, it's a hinge joint, and maybe if we get through to the first slide, we can discuss a bit about the anatomy of the knee joint. We first have the first slide. So looking into this first slide, the knee joint is composed of 3 bones. The thigh bone, which is called the femur, the shin bone, which is called the tibia, and in front of these 2 bones is the kneecap, which is commonly known as the patella. On either side, keeping this knee stable are your ligaments. On the outside is the lateral collateral ligament, on the inside is the medial collateral ligament. These ligaments prevent the knee from moving too far outwards or inwards, in other words, sideways. If we look at the next slide, and what the next slide will show us that within the knee itself, we have 2 ligaments called the anterior cruciate ligament and the posterior cruciate ligament. These ligaments prevent the knee from moving too far forward or too far backward. In other words, they are stabilizers of the knee. Between the femur, which is the thigh bone, and the tibia, which is the shin bone, we have cartilage and the meniscus. This drawing illustrates the lateral meniscus and the medial meniscus. The menisci are cushions or shock absorbers, and they prevent the bones from touching each other and act as a cushion or a shock absorber during impact or during walking or running. So with that basis on the anatomy, we can now focus on the different causes of knee pain.
Yeah, and I think that's just what I was going to touch on now, that knee pain is a common problem with many causes, from acute injuries to medical conditions. And I think perhaps that's where you can elaborate on the different causes.
Yeah, there are many causes of knee pain, and it's been stated over 20 causes. So to break it down, if we have the next slide, we could take it through the different causes of knee pain. So knee pain can be diagnosed on, first of all, on the adequate history, and then as well on the location of the pain. So if we look at this slide, if we have pain above the kneecap, above the patella, then we could be having pain in the thigh muscles, which is called the quadriceps, and here we could be having pain in the tendon. If we have pain at the back, this could be due to arthritis of the knee. If we have pain on the outside or the inside of the knee joint, this could be due to the menisci. As I said, the menisci are the cushions or the shock absorbers of the knee. If we have pain on the outside, it also could be the collateral ligaments. These are the ligaments that keep the knee stable on the inside and the outside. And if we have pain in front, this could be something called chondromalacia patella, which we could discuss, or patella maltracking, or also a bursa. In other words, the bursa is inflamed, or we also could be due to arthritis of the knee joint.
So what you're saying, Dr. Hoosen, is that knee pain can be localized or it could be diffused throughout the knee from what you've described there.
That's correct. So knee pain, there are many causes, as I've stated, and one of the other causes that we commonly see is that the patient may have referred pain. Patient has pain in the knee, but the actual cause of the pain is in the hip joint. So it's important when the patient is being examined to exclude a hip joint for the cause of the knee pain.
So knee pain is accompanied usually by physical restriction. What would your advice be to a patient if they are experiencing any form of pain around the knee?
So common symptoms that patient present with include patient has pain. The pain could be at rest or during activities, or if the patient, a classic one is called a moviegoer or theater sign, where the patient is sitting at the desk for a long time and they find that they can't keep the knee bent or flexed for a long time and they need to stand up or extend the knee. This could be a patient experiencing pain between the kneecap and the thigh bone, between the patella and the femur.
Now, knee pain can affect all age groups, am I correct?
That is very correct. Knee can start off from the young into adolescents, the middle age, and the elderly. But it's been said that the most common cause of knee pain in patients who are older than 50 years is osteoarthritis.
And what is osteoarthritis? We hear this as a buzzword. Everybody talks about osteoarthritis and talking about the off-counter osteo-ease medications, etc. So perhaps you can share that with us?
Essentially, osteoarthritis means that your bones are now rubbing against each other. Between bones, you have something called a cartilage. A cartilage is, as I mentioned, a cushion, a shock absorber. It prevents the bones from rubbing against each other. As the patients grow older, the cartilage degenerates and the bones now start rubbing against each other. When they start rubbing against each other, the patient now experiences pain. And this is what we term as osteoarthritis.
So if you can be a little bit more descriptive around the kind of pain a patient who is inflicted with osteoarthritis. Is it sharp, stabbing pains?
Okay, so osteoarthritis, they have a few symptoms that they may present with. They may present with pain. The pain that they have could be during activities or during at rest as well. They also could have a stiffness of the joint. In other words, there's a decrease in the range of motion of the joint. They may also have a swelling. The swelling may be intermittent. It comes and goes. And they may also have difficulty in walking distances. The things that we ask about in osteoarthritis is how has the osteoarthritis or the symptoms affected patients' activities of daily living. And by that we mean, do you have difficulty walking up and down the stairs? Do you need to use a railing? How far can you walk before you have pain? Simple things such as, can you put on your own socks and shoes? Do you have difficulty tying your shoelaces? Also things such as sitting in a car. Do you prefer to sit in a front seat or a back seat? Because we find that patients will prefer to sit in a front seat. There's more leg room. They don't want to flex the knee or bend the knee. Also things such as getting into and out of the bath. They may have difficulty in getting into and out of the bath. So those are the things that we look at when we're discussing osteoarthritis with a patient.
On that note, we'll pause for an ad break, and when we return, we will continue with knee pain with Dr. Hoosen. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. For the viewers that have just tuned in, our guest in studio tonight is Dr. Ebrahim Hoosen, an orthopedic surgeon who is focusing on knee pain. And Dr. Hoosen, you were talking about osteoarthritis. Perhaps you can share with the viewers more around what is osteoarthritis. You did speak a little bit to it, and the symptoms and how to treat osteoarthritis.
So as I mentioned earlier, the cartilage between the bones, which is the weight bearing or a cushion between the bones, wears away. When this cartilage wears away, we then have the bones rubbing against each other. If we have the next slide, this may illustrate it a bit better. The next slide as well, please. With this slide, we notice that the gray area is the cartilage on the femur, which is the thigh bone, which is the bone on the top part of the slide, and the lower bone is the tibia. When that cartilage gets eroded, we then have osteoarthritis, and this slide clearly demonstrates the cartilage being eroded and the bones now rubbing against each other.
So Dr. Ebrahim, this slide that you've just displayed here, is that due to acute injuries, chronic injuries, or are there other underlying medical conditions that contribute to it?
There are many causes of osteoarthritis. The most common reason for osteoarthritis is idiopathic, where there's no known cause, but the other causes include previous trauma, or patients had problems with due to taking certain medications such as steroids, or patients who are alcoholics, and those patients are the ones who develop arthritis. Regarding the treatment of osteoarthritis, first we need to make a good diagnosis or a correct diagnosis. So the diagnosis entails taking a good history, examining, and then sending the patient for special tests. And amongst the special tests we do is an X-ray. And the X-ray we do of the knee, preferably we do it person standing. And if we go to the next slide, this may demonstrate osteoarthritis. So if we look at figure 1, this figure has a normal knee on the left side. The femur, the thigh bone, is on top, the tibia is at the bottom, and we see a space between the femur and the thigh bone equally on both sides. If you look at figure 2, there the arrow clearly demonstrates there's a decrease in the joint space and the bone spur. So this is an evidence of osteoarthritis. So this shows us that the bones are now rubbing against each other. And this is one of the ways of confirming that the patient has osteoarthritis.
So now you've described the symptoms of osteoarthritis and also the kind of pain one experiences, and of course the level of functioning, how it may impact or hamper a person's daily functioning. So what, in terms of treatment and talking about knee replacement, when is a good time to undergo knee replacement? Okay.
Knee replacement is actually the last port of call before we've tried all other measures. So essentially, when a patient has osteoarthritis, the first way of treating him is conservative. And conservative entails a few things. The first thing we talk about is lifestyle change. In other words, if you have difficulty walking, maybe consider using a walking aid or a walking stick. Then if a patient is overweight, we advise patients to lose weight. It's been shown in many studies and journal articles that patients who are overweight are more prone to developing osteoarthritis of the large joints. Patients ask us, what sort of weight should I lose for it to be effective? And articles have quoted that a patient should lose approximately 5% of their body weight within a 20-month period. Then the other important thing is exercise as well. And by exercises, we mean doing low-impact aerobic exercises or swimming. And then not forgetting analgesia. By analgesia, we mean painkillers for pain relief. And the important ones, or non-steroidals, are the ones that are most frequently prescribed, or we can go to the stronger ones, which are the opiates. But a caution of the non-steroidals, it should be prescribed by a doctor who's obviously checking up for renal function, checking your liver, and making sure that the patient doesn't have other conditions such as ulcers or cardiac conditions.
Now, you mentioned all other forms of intervention before rushing into surgical procedures. You also mentioned the medication. I didn't pick up on physiotherapy. Is there any merit in undergoing physiotherapy?
Yes, physiotherapy is extremely important. That comes in with part of the exercise. What you want the physiotherapist to do is to maintain the range of motion in the knee joint, and also to keep this muscle strong. In other words, strengthen the hamstrings, strengthen the calf muscles, also strengthen your quadriceps, which are your thigh muscles. And the idea behind this is to keep the range of motion and keep the knee moving, because once we stop moving the knee, then the risk of the stiffness progressing and getting further and causing more pain.
So, for a person that is suffering from osteoarthritis in the knee, walking up and down the stairs, what is your take on that?
So, coming to the knee replacement, in other words, whether a person should have the knee replacement or not, the criteria we use for knee replacement is how bad is the pain. And typically we talk about grade 4 pain. In other words, a patient is using analgesia, but despite the analgesia, the pain still keeps the patient awake at night. And then the other thing we look at is how badly affected are the activities of daily living. And those are the ones that I alluded to earlier. If we find the patient has grade 3 to grade 4 pain with daily activities being severely or markedly affected, then we would consider a patient being a candidate for a total knee replacement.
Now, the question, there's been discussion around it that the older you are, does age have to do anything with knee replacement surgery? So if, say, one is 50 years old, does it mean that in another 10 to 15 years, the patient will require another knee replacement? Does age have anything to do with this?
So we try and delay knee replacement to as late as possible. So you're totally correct in the sense that the earlier you have a knee replacement, the more the likelihood or the chance of having a revision knee replacement. As has been stated in many journal articles, the average duration or lifespan of a knee replacement is approximately 15 years. So if a patient had to have it at the age of 50, approximately at about age of 65, 70, they would require another knee replacement. But not to say that we don't do knee replacements in young patients. Patients who are badly affected with grade 4 pain, the activities of daily living are severely hampered, we would consider doing a knee replacement in them.
So there's hope after knee replacement.
Definitely hope after knee replacement.
And what I know many people have resorted for the option of bilateral knee replacements. What is your response to that?
Bilateral knee replacements has been stated in medical journals and articles to be an acceptable form of treatment. And what we mean by bilateral knee replacements, as assume you're alluding to having two knees replaced at the same time in one setting, in one surgical procedure, in one anesthetic time. If the patient is healthy, fit, with no comorbidities, in other words, there's no medical problems to be concerned about regarding epilepsy, asthma, high blood pressure, and the patient can withstand an anesthetic for that duration of time, then a bilateral knee replacement in one setting is advised.
And what is the recovery period post-op?
So regarding the recovery period, if a patient has a knee replacement today, then the next day we would get the patient out of bed and start moving the patient. In other words, start getting the patient to mobilize. Once the patient can mobilize the knee from full extension, in other words, getting your knee straight to bending it to approximately 90 degrees, then the patient will be fit for discharge. But in overall, the time period for recovery, we would say about 6 to 8 weeks.
Okay, but it requires a lot of care and support and physiotherapy.
Exactly. After the procedure is done, the mainstay of treatment is physiotherapy. We want the knee to be mobile as much as possible and get to from 0 to 90 degrees as much as possible and get the best physiotherapy treatment after the surgery.
Now, Dr. Hoosen, you've actually brought, I see, an artificial knee replacement demonstration. You've actually got it here with you in studio. Perhaps you can actually demonstrate and share it with the viewers what the procedure entails.
Yeah, sure. So with the knee replacement, I'm just going to bring it onto the table. So what we do have in a normal person, this is the femur, which is the thigh bone, and this is the tibia, which is the shin bone. When you have osteoarthritis,
lift it, I think they can't see it. Yeah.
When you have osteoarthritis, then the femur and the tibia rub against each other, causing pain. So with a knee replacement, essentially what is done, a piece of the femur is cut off, a piece of the tibia is cut off, and that is replaced with metal implants. So the metal implants actually look like this here. This is the femur part, and this is the tibia part. So this is the metal part of the tibia, and overlying it is the plastic liner, called a polyethylene liner. So the way this is done is that after taking off a piece of the tibia, the metal is inserted with the plastic liner, and that fits into the tibia, and then the metal femoral component is inserted into the femur, and after all of that is done, we now have a patient who has a knee replacement. And as you can see, we have a metal articulating with the plastic, with the metal as well. And that is how a patient with a knee replacement would look like after the surgery is done.
Wow, that's awesome, Dr. Hoosen. Quite encouraging for patients to go for that procedure. On that exciting note, we'll take an ad break and continue with Health Matters. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. Our guest in studio tonight is Dr. Hoosen, who's been speaking about knee pain and osteoarthritis in the knee and knee replacement surgery. Now, Dr. Hoosen, you mentioned about the success of the knee replacement. I would like to explore a little bit around the issues of injecting steroids and injecting pain for the knee?
Okay. So the injections that we do have for the knee, the two broad groups or categories are the steroid injections, and the other one is called the visco supplements. Steroid injections is exactly as it says. It's a steroid that we inject into the knee. For this year, it's been prescribed or recommended to inject approximately 3 to 4 times a year, but not more than 4 times a year. Regarding the visco supplements, it is something called hyaluronic acid. And within the knee joint, you have something called a synovial fluid. The fluid is what lubricates the knee joint and prevents the bones from rubbing against each other. Now, with the visco supplements, it's been thought that by injecting this hyaluronic acid into the joint, it will increase the levels of hyaluronic acid into the joint, and that may assist in with knee pain. But I must emphasize that the studies that we have received regarding these visco supplements are mixed, where you have some patients saying that they have good pain relief, but others have no pain relief. Also, another thing on the visco supplements is that it's been shown that patients who receive them in the early stage of osteoarthritis may receive benefit. But once a patient has stage 4 or advanced osteoarthritis, then visco supplement has not been shown to be beneficial.
Dr. Hoosen, the off-the-counter stuff like OsteoEase, what is your take on that, or what is your response? Does it have benefits? Does it have any merit? Okay,
so the OsteoEase, that's a trade name of one of the drugs, but there are many similar drugs, and the majority of these over-the-counter medications have 2 components, which is glucosamine and chondroitin. And regarding glucosamine and chondroitin, the idea behind this here is that it will help with the osteoarthritis. But from a medical or journal point of view and a scientific point of view, if I quote the osteoarthritis research scientific information, or it's called the ORSI unit, what they have stated in their latest guidelines, which is the 2014 guidelines, that they think that it's regarding the chondroitin or the glucosamine, that it is uncertain. They have no conclusive evidence that it does work. So they don't say one should not use it or they should use it, but their recommendation is that it's an uncertain drug to be using. So what I recommend to my patients, if you find that you start using it and it causes you, it decreases the pain, then I would say continue with it. But after 2 or 3 months you find there's no difference, then maybe consider changing into something else.
Just to remind the viewers that the lines are open, please feel free to call in on 011 086 7777. I repeat, 011 086 7777. Dr. Hoosen, you mentioned earlier on about weight loss, the importance of weight loss, exercise, pain therapy. So what you're actually suggesting is it's a whole shift in lifestyle in addressing knee pain.
Correct. So as I mentioned, that we have to have a lifestyle change, because what you find is that one may treat the pain by giving analgesias, non-steroidals, but if we're not keeping up with the exercises or we're not losing weight, then we're not going to achieve much. All we're going to do is just treat the symptoms. So essentially, a lifestyle change is important in the entire thing. I must just add that regarding knee replacements, if we look at the latest literature, it's been stated that in the US, there's a 3 times increase in the number of knee replacements done in the last few years. And regarding in the UK, there's been an increase, 8 times increase in knee replacements done. And this has been quoted in patients over the age of 65 years.
Dr. Hoosen, we have a caller on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam. I'm inquiring because I've now turned 50, but for the last 2 years, I've been having a problem where if I bend, I can't get up. I need people to help me get up. For the last 2 years,
Sister, can you switch off the TV, please? Well, because we cannot hear you. I don't think Dr. Hoosen can hear you.
1 second.
Hello?
Hello, it's off now.
That's fine, sister. Please go ahead.
I've been having a problem in the last 6 months to a year that when I'm bending and I can't get up.
Okay, I think I got the gist of the question. What the sister has said is that when she bends down, she's unable to stand up. Sister, are you still online? Do you have any problem with the knee per se? In other words, do you have any pain in the knee? Okay, I think we've lost the sister. The things to look at regarding this here, what I would like to have known is whether you are able to fully extend the knee, in other words, make the knee straight. What I'm trying to find out is, do you have any locking symptoms? So by locking symptoms, what can happen is that the meniscus, which is the cushion or shock absorber, could tear or have could tear. And once it tears, it sort of acts as a blockage into the knee joint itself. In other words, because there's now a foreign body or something that's blocking the knee from fully extending, this can cause you to be unable to extend your leg. In other words, fully straighten out your leg. So what I would recommend is that have this properly assessed by an orthopedic surgeon. It not necessarily could be the knee. We have to have a look at the hip joint, because as I mentioned earlier on, the hip joint also could be a cause of pain within the knee.
Okay, we have another 2 callers on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Hello, wa alaikum salam.
Go ahead, brother.
Calf muscle, pain in the calf. What is the cure for it?
Look, calf muscle pain, there's a few things that we need to do, because it can be a wide range of things. Is it an acute thing or is it a chronic? And what type of pain is it? Is it a sharp stabbing pain? Is it pins and needles? Is it after sport, before sport? So
no, while playing sports, tennis.
Okay, so then the things that we have to look there is it a muscle sprain or a muscle strain? Or the other thing is sometimes we can have pain from the back. In other words, you have pathology in your back, and that could be causing you to have pain in your calf. So those are the kind of things that we look at. Also, do you have any pain in the front? Is it in front of the tibia? In other words, anteriorly, do you have any pain there as well?
No, I'm having pain at the muscle, the calf muscle itself.
Yeah. Look, the things that we have to look at, as I said, is we have to exclude if there's any cause of a back pain that could be causing you to have pain in the calf. In other words, sometimes when you have a disc prolapse, you can have referred pain to the calf as well. Then the other thing is to look at the muscles itself. Is there any evidence of a muscle spasm or muscle sprain or strain? And then the other thing is just to exclude, very unlikely, but just to see if you don't have any compartment syndrome that's developing in the calf. Those are the kind of things that we look at. To be honest with you, ideally it would be best to examine the calf, see what the calf feels like. Is it swollen? Is it bigger in size, smaller in size? Do a full neurological examination. Examine also the knee and the ankle and see what we're dealing with as well there.
The next caller on the line, please go ahead.
Hello, assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh. Please, can you tune your TV down so that your question can be heard?
Hello, assalamu alaikum.
Wa alaikum salam.
Can you hear me?
Yes. Go ahead, please, brother.
You know, I have pains in my knees, mostly when I'm sitting. For quite a while, when I get up, I struggle to get up. And then mostly when I'm sitting in a car, driving from one place to another place, when I get off from the car, it takes about time for me to start walking straight. I just have severe pains in my knees.
If I may ask, how old are you?
I am 63 years old.
Okay. As I mentioned earlier, that one of the causes of knee pain is patellofemoral arthritis. In other words, between the kneecap and the thigh bone, the femur, one may develop arthritis. So what that means is that you have your kneecap, and behind your kneecap you have cartilage. The cartilage is a cushion or a shock absorber. It prevents the kneecap from touching the thigh bone. If you have the erosion or degeneration of this cartilage where this cushion wears away, then the kneecap rubs against the thigh bone, and this can causing pain. So we classically see it in patients who have to sit for a long period of time, where the thigh bone and the kneecap are very close to each other. And when you want to get up, this has now causes you to have pain and difficulty. So I would think, just from listening to your history without doing an examination, that the problem is probably between your patella, which is your kneecap, and your thigh bone, and you may be developing arthritis between the kneecap and the thigh bone.
Shaheda, I'm on Voltaren medication. I take Voltaren for my pain.
Okay, so Voltaren is one of the non-steroidals. The thing is that you've been treated for it, but you have to make a diagnosis, and depending on a diagnosis, then we can decide what to do for the treatment, because there are many treatments for patellofemoral arthritis. So what I would suggest you do is see your physician or see your orthopedic surgeon. One of the investigations they would do an x-ray, and that will help us in diagnosing whether you have patellofemoral arthritis, and then we could take it further from there.
You see, doctor, I've been going to the hospital for the last 10 years, and I've been treated at the hospital, at Paraguana.
Yes.
By Dr. Magda.
Okay. So, do you have any evidence of rheumatoid arthritis? Have they investigated you? Have they investigated you for rheumatoid arthritis as well?
Yes.
And do you have rheumatoid arthritis?
Yes.
So that could also be causing. So essentially, what you do have is that you may be having arthritis, as I've mentioned, between your femur, which is your thigh bone, and also between your patella, which is your kneecap. And the reason I say this is because you have your pain, especially after sitting for long periods of time or when trying to get up, as evidence when you say you're sitting in a car, you have difficulty getting up.
Okay, thank you.
Okay, shukran.
Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh. We'll now take a break, an ad break, and continue with Health Matters. Welcome back to Health Matters. We will continue with the Q&A, the question and answers. We've got two callers on the line. Please, can you go ahead with your question to Dr. Hoosen?
Assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh.
How are the doctors tonight?
Alhamdulillah, I'm well. And how are you doing?
I'm good, shukr. Listen, I'm sorry to disturb you. I just wanted to find out. A few years ago, I had an accident with rugby. So my knees was buggered, but I just put it back into place. And it didn't really bother me. But I'm seeing now in the winter, when I'm making my salah, when I come up from sajda, it's terribly sore. So now I don't know what I need to do. Should I go get it checked out further, or what should I do?
Brother, how old are you?
I'm now 34.
And when was your knee injury?
About 10, 12 years back.
Okay. Did you have any fractures at the time? Was there diagnosis of any fractures, any broken bones?
No, nothing.
Okay. So with sport injuries, the common conditions that we do have are the ligaments that get injured or torn. So as I mentioned earlier, within the knee you have anterior and posterior cruciate ligaments. These ligaments prevent the knee from moving forward or backward. In other words, too far forward, too far backward. And then also within the knee, you have the menisci. The menisci are the cushion or the shock absorbers. And in rugby or the twisting type of sports, the cruciate ligaments or the menisci are prone to getting injured. And if you have injured any of these, maybe 10 years ago and you did not diagnose it or did not pick it up, this may be the reason why you're having pain presently. So I would think that you probably have a problem with your cruciate ligaments. If it's not that, then it's probably with your menisci. And by examining you clinically, one could make a fairly firm diagnosis on what exactly we're dealing. So I would suggest, as your question states, yes, you should see someone, and ideally an orthopedic surgeon, or otherwise start off with your GP and take it further from there.
Okay, thanks a lot. out. I just want to find out also, you see, because I have to perform salah on a chair, it's much easier. But many brothers are saying it's not allowed. Is there any ruling that you can give?
Unfortunately, I think that would be more addressed with one of the ulama in your locality.
Assalamu alaikum.
Wa alaikum salam.
Walaikum salam wa rahmatullahi wa barakatuh. We have the next caller. Please go ahead with your question to Dr. Hoosen.
Hello.
Please switch off the TV so Dr. Hoosen can hear your question.
Right. Assalamu alaikum.
Wa alaikum salam.
Walaikum salam. Your TV is still on. Please turn the TV down.
Turn it here. Jazakallah. Assalamu alaikum, doctor.
Wa alaikum salam.
Doctor, I'm just curious to know about I don't have any knee problem as such, shukr to Allah so far, but what I need to know, because I do some exercising first thing in the morning when I get up. I mean, you do have to do some exercise, I mean, for your body, otherwise you find your body aching and paining and all that sort of thing. So I do some running on the treadmill. And some people tell me that when you run on your knee, you know, by running, it can damage your knee and can cause various types of harm to your knee. So I just want to know from you, doctor, whether it is so, or shall I carry on with that running that I'm doing, or must I stop it, or what must I do, doctor, just to prevent it from any harm, doctor? Thank you.
All right. So what we do, okay, no problem. What we do say is that exercise is good, but we find that if patients already have developed osteoarthritis, whether it's early osteoarthritis or late osteoarthritis, then those patients, we advise them not to do impact sports. So impact sports such as running are not advised, because essentially what you're doing is that you rubbing the femur, which is your thigh bone, against your shin bone, which is your tibia, and causing more pain and more inflammation in the area. So in that instance, we then advise the patients to be doing low impact sports. So things such as aerobics, which is otherwise walking, or other things that we do suggest is sports such as swimming. But if you're having pain in the knee and it's probably a sign of early osteoarthritis, then our recommendation is not to do running, because this is a high impact sport which will worsen your condition.
Okay, shukran, Dr. Hoosen. I think we've come to the last section of the discussion, and perhaps you could take this opportunity to summarize and give a few take-home messages to the viewers out there.
So as I mentioned in the beginning, that knee pain is a very common condition affecting approximately 25% of adults, and it affects everyone from young age all the way up to late adulthood. So regarding knee pain, I would suggest that if you have knee pain, see your GP, and if your general practitioner is not comfortable with the condition, then maybe he or she would refer you to an orthopedic surgeon. And inshallah, that way we can get an early diagnosis with what's causing the knee pain. Because as I mentioned, there are probably over 20 conditions causing knee pain. And a lot of the conditions, if we treat them early on, we can prevent the later onset or the later manifestations of that disease.
Now, you said something very interesting earlier on. You mentioned about back pain and the knee pain could actually be referred pain from another area.
Yes. Okay. So hip pain can also be referred to the knee pain. So we do find at times patients complaining of pain in the knee, but the pathology actually is within the hip joint itself. And patients who have problem in the back, they may have pins and needles or pain that runs down the leg, and this would also cause them to have knee pain. So that's why a thorough examination includes a back examination, a hip examination, as well as the ankle and foot examination. Because if your biomechanics is incorrect in the lower leg, this will affect the knee joint as well.
And in terms of lifestyle, if you can just summarize quickly.
So regarding lifestyle, if a patient has developed osteoarthritis, then we always start off with conservative management. And as I said, exercise is always good, maintaining a range of motion of the knees, also to lose weight. As I mentioned, I can't emphasize the weight loss because the majority of journal articles will confirm that osteoarthritis is related to an increase in body mass index, and also using walking aids if that will help you in mobilizing better.
Okay. Shukran, Dr. Hoosen. I think that's been a very informative, enlightening discussion, and I think it's also encouraging to know that there is life after knee replacement, that there is hope for patients out there who are suffering with knee pain. And as you've indicated, that people need to seek professional intervention, going to see their general practitioner and orthopedic surgeon to get the specialized intervention. And on that note, we will end with a verse from the Holy Quran. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Wal asri innal insana lafi khus illa alladhina amanu wa amilus solihati wa tawasaw bil haqq wa tawasaw bis sabr. Sadaqallahu al-azim. Until Health Matters next week, we will now conclude. Shukran dalilan.